beautifully done surgery. Now, the first line of treatment in glaucoma is definitely medical, but we cannot undermine the importance of surgery in glaucoma. And trabeculectomy is a forgotten art, very truly said, but why trabeculectomy is a lost art? Revisiting the foundations of glaucoma surgery in the era of quick fixes. Let's hear from Dr. Mohammad Azimi.
मुझे तो ऐसे लगता है कि आजकल सिर्फ और सिर्फ एक ही काम आई डॉक्टर्स कर रहे हैं, फिक्स द corneas and remove the lenses, remove the glasses only. So I don't have any financial interest or I don't have evidence. So my trabeculectomy must be preserved, especially in advanced glaucoma and rapid progressive disease, because it is the only art which can attain a single digit IOP. I see many cases who have advanced glaucoma and they have rapid progressive disease and still trabeculectomy is not offered. Why? So this is a study done by doctors that shows that over a 5-year period, it goes approximately low dense, approximately to 10 millimeter of mercury with the help of trabeculectomy with MMC. So here is another reason, as the quality of life improves and aging population increases, so longevity increases, the catastrophic disease and rapid progressive disease. So that's another reason we should preserve trabeculectomy with MMC. So where we are living in social media era where everything is fixed with the help of lasers. If people ask if you can correct my misalignment with the help of laser, you can correct my retinitis pigmentosa with the help of laser. You can fix my old detachment with lasers, and this information or misinformation all spread through the media. So we have to fix all those problems. And so what happens when we do not do trabeculectomy with MMC? When we do few procedures like trap, it leads to less skill. And one of the reasons it is less done or less skill development is its post-operative demanding management. So when we do a cataract surgery, patient comes and he just goes, and similarly in other procedures like LASIK, open LASIK, patient comes and goes, that's easy money. But in the case of trabeculectomy, it's not that easy. You have to manipulate the sutures, you have to look the IOP. So early post-op is really important. So how I came to know this about the role of trabeculectomy, there is an organization, I heard about this organization, which is known as BPUS. I don't have any financial interest in those people. Dr. Rashid Zia is sitting. I heard him first here in this conference 4 or 5 years back, and then I followed up the guy. So what they do is, they have a structured program, they have a curriculum, they are very flexible people, like they know you are in private practice, they know your social problems, they don't force you, and they are up to date. So that's one of their good points. So these are the few terms which they use, and I never heard in my 5 to 10 years of ophthalmology these terms before getting enrolled in BQS fellowship. So here are a few terms which I heard first time. Hysteresis. I never knew what is hysteresis unless I went into the fellowship. The other point was profuse pressure, DBLS, disc damage likelihood scale. The other was trabecular outflow. The other was neuroprotection, needling, and not last but not the least, cataract surgery in small eyes. So this is the curriculum which we followed a little, which they keep on updating. The next is they rely on these few studies, which is Hood's report, Light studies, ZAB, and Eagle trials. So these studies cover pretty much of the treatments which we commonly do. Like in Hood study, it follows the structure and functional damage of the disease, how and when we do the trial. It follows the patient and detects its functional and structural damage. And then there is a light study. What light study covers is the use of SLT, very popular these days. I've seen many senior people, very respectable people offering SLT to very advanced glaucoma patients. However, this still says that SLT is only offered in early glaucoma patients. And then there is ZAB and Eagle. ZAB and Eagle only covers the angle closure patients. So these are very important studies for the glaucoma patients. One should have looked on its outcomes. So I put on my WhatsApp a question to my senior colleagues. These are the few replies which I got when I put this question in my WhatsApp. This is the first response from a very senior ophthalmologist, where Aslavan is a retired professor. Why do we not do trabeculectomy with MMC anymore? Not all patients, but in progressive disease glaucoma patients. He said, not all doctors are at home. They are not comfortable. So, here's another response. He said that when the real field is too much deteriorated, we should not offer, because he is not sure that he will be able to control his trial. He's here in this response, he's worried that his trial will make the patient blind. Here is another response. He's my level of senior level doctor, like middle aged. He said that we should not use MMC at all. And here is my friend, Jan Karturain. Way forward, but what should be the way forward? Strong training program, preserving the traditional glaucoma culture, which used to be there when these drops were not here, prostaglandin analogs and brimonidine, all the drugs were not here. Our seniors used to do trabeculectomy very regularly. So then the drops came and the trabeculectomy went down, and so he lost the art. And then there is financial reimbursement. Glaucoma surgeons should be paid well, but it is hard. And then the coming generation, it will not preserve the art. How can we make aware them or encourage our young colleagues to learn the art? The next one is another very important thing. A person like me who is not working in a big hospital, how should we scrape the information? So I find it very interesting how ChatGPT works. ChatGPT scrapes the information from social media platforms like Reddit, Medium.com, Quora. So what we can do is we can go and join these communities of glaucoma or trabeculectomies on these platforms and put our queries over there. And we have a social contact all over the world and get our feedback. And there is a response I liked very much from Rashid in one of his talks. He takes us like, he treats us like a nursery or primary kid. Whenever we have any question, he just wakes up at night, 1 a.m. or 2 a.m., whatever the time is, and he'll respond, okay, you can do this. He will say that he still, no, I think he's a guru, but still he says knowledge is rudimentary at its best. Glaucoma knowledge is rudimentary. Still, this is a man with a lot of humbleness. So I leave the question to you. Is this a lost art? I don't think it is a lost art, but we need to refine it. Thank you.
Thank you, Dr. Z. Beautiful talk. Any questions? Yes. Mic दे दीजिए पीछे इनको. I'm sorry for my sore throat. I had laryngitis for a few days. मैंने डॉक्टर मोइन से कहा भी था कि I would not be able to do it. But you know,
any residual began, like his MPL, and if he is fit for glaucoma surgery, we should go for TRAB or not?
Thank you very much for the question. NPL के साथ तो I would not suggest to do TRAB. NPL है तो you can do cycle diode laser. Lekin if the patient is perception of light, hand movement, counting finger, then TRAB can work really well. Because even in later stages they may have temporal island of vision, and if you have hand movement vision and you do a proper TRAB, especially in younger patients who are like in the 30s and 40s, yet their vision may improve to 560, 660. I've seen one patient improving to 618. So it's worth doing it, even if vision is very poor, but not an NPL patients.
Sir, can we give medical treatment at first for any improvement? If there is any improvement of IOP, then we go for TRAB.
So this is a huge topic. The first thing is the multiple trials that like TAGS trial, etc. They all encourage early trabectomy. Trabectomy is still the gold standard. We don't have to preserve this procedure. This is the answer. The surgeons who do not consider TRAB as the mandatory skill, they all need to go back to the training. So this is a mandatory skill that every glaucoma surgeon needs to know. And so the TAG trial suggested that before the eyeball gets toxic with the eye drops, so whenever a patient comes to me from Pakistan, he is on 4 drops on acetazolamide, totally toxic, totally ignored eye. That's negligence. You don't want to operate in an eye which is toxic because the conjunctiva shrinks, the eyeball becomes tight, orbit becomes tight, and the outcome of the surgery is less favorable as compared to a treatment-naive eye or an eye which hasn't been destroyed by preservatives. So it's best to operate early. So that's why trabeculectomy is an essential tool. It's still the gold standard. So we have alternatives to TRAB, like we do Presoflow nowadays, but it's not an alternative to TRAB. So I do less and less TRAB now because I have alternative to TRAB. I have Presoflow, but still there are many patients where I will not choose Presoflow and I'll still choose TRAB. But whatever the reason, we do surgery early.
Sir,
there is one more question from the back.
thank you, sir.
Thank you. I would like to, since sir is also here, so my question is that should we update our guidelines that TRAB should be the primary treatment for glaucoma patients?
So this is all the TAGS trial is all about. TRAB as if you have an advanced disease on presentation, do TRAB. So this is what TAGS trial is all about.
Is it only for advanced diseases or like any glaucoma patient that is diagnosed as a glaucoma?
No.
And you label it as a glaucoma patient?
No, not in Pakistan. This is a question which demands a holistic approach. So because if you do not have an access to regular follow-ups, if you do not have access to regular eye drops, if the patient education is not at par with your consultation, so you can't really offer TRAB. TRAB needs a lot of follow-up, lots of follow-ups. And on average, you need 17 to 20 follow-ups a year, sometimes even more. So you can't really offer it to every patient, but advanced disease, when it comes at the presentation, do TRAB.
Thank you, Dr. Zia, for
So sometimes we get patients who have only temporal island of field, and TRAB is possibly the only answer. I know there is a risk of wipeout, but this wipeout concept is, I think it's been wrongly addressed to TRAB, because in olden TRAB, used to get hypotony. That's dangerous. That will wipe out the field. So in modern TRAV, we don't get hypotony. You get high pressures post-op and then you titrate it down. So in modern TRAV, you don't get hypotony, and hence the wipeout is not really there. Wipeout is actually present following cataract surgery in advanced glaucoma patients where MIGs haven't been done or alternatives haven't been done. That's a problem of cataract surgery, not glaucoma surgery.
I think which first eye predicts the outcomes in the fellow eye. Bilateral trabeculectomies, associations, and differences. Let's hear from Dr. Hira Mozum. Please can you?
Trabeculectomy in one eye predicts the surgical success in the fellow eye. No conflict of interest to disclose. Glaucoma is the leading cause of irreversible blindness worldwide, and trabeculectomy remains the crucial surgical intervention for managing advanced glaucoma, and it is still considered the gold standard. Studies have shown that the outcome of trabeculectomy in one eye can predict the surgical success in fellow eye. This inter-eye correlation has significant implications for clinical decision-making, early surgical intervention, and patient counseling. Understanding the factors influencing the correlation can help optimize the surgical outcomes and improve the patient care. So a prospective and retrospective cohort study was carried out from 2022 till 2024 in Ashraf Trust Eye Hospital in the glaucoma department to understand this inter-eye correlation. Patients with different types of glaucoma who underwent bilateral trabeculectomies were included, and the patients were followed at 1 week, 3 months, 6 months, 12 months, 18 months, and 24 months intervals. So, in this study, the surgical success was defined as complete success, cumulative, and failure. The complete success was defined as intraocular pressure of 16 millimeters of mercury or less than it, and at least 20% reduction from the baseline intraocular pressure without any intraocular pressure lowering medications. Cumulative success, which was defined as IOP of less than or equal to 16 millimeters of mercury or more than 20% reduction from the baseline IOP with the use of intraocular medications. And failure of was intraocular pressure less than or equal to 6 millimeters of mercury or more than 16 millimeters of mercury. Between 2022 to 2024, 186 eyes of 93 patients were included in this study, and the follow-up time was 54.34 plus minus 41.13 months for the first operated eye and 44.13 plus minus 34.38 in the second operated eye. So the complete success in the first operated eye was 78.2%, and in the second operated eye was 80.3% with a p-value of 0.002. And the cumulative success in the first operated eye was first operated and second operated eye were equal 80.3% with a p-value of 0.012. This is the graphical representation of the same that I have discussed. Rates of the post-operative complications were similar in both eyes, and so there was no statistically significant difference in terms of the outcome in both eyes. So why is this so? Several inflammatory mediators and immunological mechanisms influence the surgical outcomes of trabeculectomy in the fellow eye. They are like prostaglandins, which are released during the surgery, increase inflammation and affect the eye. Cytokines like interleukin-1, TNF-alpha, and other cytokines promote inflammation and fibrosis in the fellow eye. Growth factors like VEGF and TGF-beta can influence the wound healing and scarring in the fellow eye, and immune cells like activated T cells and macrophages can migrate to the fellow eye, promoting inflammation and modulating the healing process and response. These mediators affect the fellow eye through the systemic circulation and also through diffusion through the ocular tissue. So, also there are some sympathetic changes and neural signaling that affects the fellow eye. That is, when trabeculectomy is performed in one eye, the surgical trauma that activates neural pathways which connect both eyes, and this is referred as consensual ocular response or sympathetic crosstalk. Surgical manipulations stimulates nociceptors and sensory fibers in the operated eye, and these impulses travel via the trigeminal nerve and the optic nerve, and thereafter reach the central processing system in the brain. And these signals reach trigeminal nucleus caudalis in the brain, and the brainstem acts as an integration center. And once it is activated, it triggers a response in both eyes, not only just in the operated eye. Also, there are autonomic reflex output from the trigeminal nucleus. Reflex pathways activate the autonomic nervous system, especially the sympathetic branches which cause vasoconstriction, alter aqueous humor dynamics, and parasympathetic branches which influence the vascular permeability and inflammatory mediator release. These all neural reflexes lead to bilateral physiological effects, even though only one eye underwent the surgery. Lastly, because of this cross neural communication, the fellow eye shows altered vascular tone, increased inflammatory susceptibility, modified fibroblast and wound healing responses, and changes in aqueous humor production and outflow. All these factors together influence the surgical outcome of the second eye, making it somewhat predictable based on the first eye's response. So, concluding, trabeculectomy in one eye is a significant predictor of the success in the fellow eye, and the patient who achieve cumulative success in their first eye are 6.5 times more likely to achieve the success in the second eye. Thank you.
Thank you, Dr. Hira. Any questions? Yes, Dr. Zara. Yes, Dr. Rashid.
Thank you. Excellent lecture. Very good points. The points I wanted to get. The thing is, not all open-angle glaucomas are the same. Even if you cannot categorize an open-angle glaucoma patient into a subcategory, they are all different. So their ACs have different prostaglandins, tumor necrosis factor beta. There are many different chemical mediators. That's why if you look at the World Glaucoma Consensus Statement, you will see the higher intraocular pressure is actually a negative predictor for the outcome of the surgery. And that's because higher the pressure, more are the chemical mediators. That means more aggressive your post-op treatment needs to be. So this is very important. Which means what you're trying to highlight is that not all glaucoma patients are the same.
Yes.
But both eyes could be similar, provided they have the similar pressures, opening pressures. And I presume you're talking about not the confirmed diseases like pseudoexfoliation, etc., because they will be similar. The other thing is the technique itself. If the first eye has been operated by a poor technique and the second eye has been operated with a better technique, it will have a better outcome. So technique is also very important. Thank you.
My question is a very nice presentation, first of all. Depending upon these factors which you have mentioned earlier, so the time interval to operate the second eye and how long these changes do take. So what is the ideal time period in your experience when you operate the first eye and want to operate the second eye? Is there a consensus or it's just the personal?
If we had successful surgery in the first operated eye, then we usually go for trabeculectomy in the fellow eye earlier.
Earlier the better.
Yeah.
That's right.
Thank you so much. Now we are honored to have Dr. Huma Shahid from my voice, so like Dr. Samal, also suffering from the local version of laryngitis. So with my talk, I'm hoping that we can bring back trabeculectomy because I think it's a key skill that any glaucoma surgeon needs to be able to offer. So in recent years, there have been significant developments in the management of glaucoma. We have better medications, we have laser treatments, we have the evolution of the minimally invasive glaucoma procedures, and therefore there has been a slow decline in the role of trabeculectomy. Nevertheless, it remains the commonest and most successful procedure for glaucoma worldwide. So I'm not sure how many of you know this, but the story of trabeculectomy began in Cambridge, which is where I work. This is a restaurant called the Little Rose Restaurant, which is situated just outside Addenbrooke's Hospital, and it's where many of the senior doctors used to gather at the end of the day. And Peter Watson, who was still alive until a few years ago, described how literally they drew the operation on the back of an envelope. And then himself and John Cairns decided that that was what they were going to do. Now, at that time, the thinking was that the diseased area was the trabecular meshwork. And that's why the name trabeculectomy, if you think about the operation that we do, it doesn't match the name. So what they decided that they were going to do was to excise a section of the trabecular meshwork. And by doing that, that would encourage flow through the remaining outflow system. If you haven't read the original publication, I would encourage you to read it because it makes very interesting reading about what the thinking of trabeculectomy and the science of it was. So in the paper, if there was a bleb present, those patients were classified as a failure. So it was never intended to be an operation which led to bleb formation. So it's evolved with, and it's developed with our understanding of how the surgical procedure is actually working. But if you had a bleb in the original series of patients, they were classified as failures. If we think back to the time, so when that first paper was published, what was going on in the world? So man landed on the moon, Muhammad Ali won his first heavyweight boxing title. So many of us, are too young to remember these events. So it just goes to show that trabeculectomy has been around for a very long time, 56 years. And it's remarkable that we're still using that technique, and that's real testament to its success. So in Cambridge, we have the longest series, follow-up study of trabeculectomy. This one was published, this was the 20-year follow-up, so we are now looking at the 30-year follow-up, which will be published. And the success rate is phenomenal. So this looked back at a group of 234 patients. Now, they are predominantly Caucasian patients, and at the end of 20 years, approximately 60% of trabeculectomies were successful without the need for medication. And the qualified success rate, that means they needed medication, the qualified success rate was 90%, which is a really good outcome. And remember, in those days, antimetabolites were not being used, so there's no mitomycin. These were all unaugmented trabeculectomies. What the paper showed, these are survival curves for different types of glaucoma, and it showed that trabeculectomy worked best for simple primary open-angle glaucoma with no other risk factors. So obviously this topic has implications for training. So this is a paper looking at surgical outcomes from trabeculectomy, and it compared trabeculectomies performed by trainees and performed by more senior surgeons. And essentially the outcomes were similar. So after 2 years, there was no difference in the eye pressure readings, the visual outcome, or the failure rate in operations that were done by junior surgeons and senior surgeons. But where there was a difference was in the early postoperative complications, and particularly leakage around the bleb sites, which reflects the fact that we need to target areas like conjunctival handling and suturing. So trabeculectomy surgery is technically demanding. You do need to have proficiency in suturing. And before with cataract surgery, you would always suture the wounds. And that's kind of largely gone now. So therefore, that's a skill that needs to be practiced. Your first trabeculectomy will always have the best chance of success. Anything after that, your success rate is going to be diminishing. And the conjunctiva is a delicate tissue. It doesn't forgive if it's mishandled well. So I'm just going to go through my trabeculectomy technique just to give everyone a flavour of how I do trabeculectomy, what I do, how I do it, why I do it. And there's always a reason behind my technique. So these are the basic steps of trabeculectomy. So it's a guarded partial thickness filtering procedure performed by removing a block of peripheral cornea underneath the scleral flap. So the scleral flap provides resistance to outflow of the aqueous, and that will help you avoid the complications associated with hypotony. I don't always use mitomycin C, so I plan to use it in everybody, but in many elderly patients, you may find that the conjunctiva is extremely fragile and friable. Don't use mitomycin in those patients, they don't need it. If you do, you will often get melting of the conjunctiva and you will find it difficult to complete your surgery. So I tend to position trabeculectomy superiorly so that ultimately the blood will be located under the upper eyelid, and it also protects against infection and blood leak as well. Obviously, it's not always possible if there's scarring, etc. It's also easier when you're trying to access the eye for surgery, and there's less risk of blood dysesthesia. So blood dysesthesia is when patients will describe discomfort, dry eye symptoms after glaucoma surgery. You may see that more in a younger patient, supranasal trabeculectomies, or if there is poor eyelid coverage. So again, nasal blebs tend to give you lower pressures, but more likely to be uncomfortable afterwards. So just sort of running through, I'm just going to hope that some of these videos will play. Let's see.
Have you got a video on the folder? You can minimize and use it on the. You got a folder on that.
There's no folder, these are embedded, so they should.
Yeah, they don't always work.
Okay, anyway, it doesn't matter for this one. So I tend to give pilocarpine on the table at the start of the procedure. I don't give it before on the ward because there's always a mix-up, and patients who are having cataract surgery get dilating drops, and then somebody will dilate the pupil of the eye that's having trabeculectomy. So if you just put one drop at the start of your trabeculectomy, by the time you come to do the surgical iridectomy, it will have worked. And pilocarpine is important even if your pupil looks small, because manipulation within the eye during surgery, or if you use topical adrenaline, you can sometimes get pupil dilation, and you can end up with a keyhole pupil at the end of the procedure. I'm really sorry that these videos aren't working. We did check them. Should I do the center? These videos are on loop, so if anyone wants to watch them, they can come and look at the computer afterwards. So I use a corneal stay suture with 704 micron on a curved needle. That avoids superior rectus muscle hematoma. You're going to use a traditional bridal suture. You don't want to go full thickness into the cornea. If you do, you will get a leak, and it will be difficult to cut your scleral flap because the eye is not firm. So if you find that you've gone full thickness, just do it again. Don't kind of try, because otherwise you'll have to keep inflating the anterior chamber. I tend to start my peritoneum using Vanna scissors because you make a much smaller cut, and it will help you identify the correct surgical plane, which is literally all the way down to sclera. And I do make a small radial cut. If you don't do that, you'll find the conjunctiva tears. And then I'll use a pair of Westcott scissors to cut radially close to the limbus. I use a lot of diathermy. I don't want any blood vessels where I'm going to cut the sclera or where I'm going to be placing a suture needle. MMC, 0.2 milligrams per mil for 3 minutes. I use the corneal shields cut in half, and they're positioned under the conjunctiva as far back as you can. You don't want the mitomycin to touch the edges of the cut conjunctiva, otherwise you're more prone to wound leaks. And once you've removed the sponges, you want to wash that area again, lots of saline. I will measure the area where I'm going to create the scleral flap. So generally my flap size is about 4 by 3 millimeters. I use a diamond knife. I know a lot of people stopped using diamond knives, but it gives you fantastically sharp edges. it is a very sharp knife, so beware if you're not used to handling it. And then I use a crescent blade to actually dissect forwards. Now, if you'll notice, the cut edge of the flap doesn't extend all the way to the limbus. When you're starting out, it's a good idea to cut to the limbus, but just be aware that you will likely need to place anterior sutures if you do that to avoid anterior drainage. After this stage, I've not gone into the anterior chamber, I'm going to pre-place 2 tenor nylon sutures at the corners of the flap. I'm then going to use an AC maintainer, so it's a 23 gauge maintainer. And the reason for that, there's lots of reasons for using an AC maintainer. Number one, it will avoid hypotony during the procedure. And more importantly, it's going to help you gauge flow. And we'll talk about that in a minute. So there's your AC maintainer, which is usually positioned temporarily. So then we're going to enter the anterior chamber under the scleral flap, and you want to use a punch. And when you use your punch, you want to position the punch as perpendicular to the eye, and you don't want to create a shelved incision. It's got to be a crisp opening under the scleral flap. You have pre-placed your sutures, so what you can then do, so I've missed out the iridectomy, so then you perform your iridectomy, and then you're going to close. Now, as you're closing, what you'll notice is there's copious egress of aqueous at this point, or reassess, because you have an AC maintainer. Now, when you put the flap down, without closing the sutures, if you have no flow, that tells you that your sclerostomy is too small. So it won't matter whether you have stitches or not. So what you actually want is, even when the flap is positioned down, you still want to see flow. That's where the value of your AC maintainer will come in. You're then going to close your sutures, so nylon sutures, 3 throws, 1 throw, 1 throw. And then often, if I need to, I'll place an additional suture, which is usually an adjustable suture, which is a little bit like, so some people put them through the cornea, or you can keep the posterior. And then we're going to close the conjunctiva after that. So I tend to use 2 wing sutures, and again, we're going to use the 3-1-1, but I put a couple of extra throws on, and then I cut on the knot, or even through the knot, because you'll get a really crisp suture. It won't irritate the eye, and you can cut on the knot if you put some extra throws on without destabilizing the knots. So what I'm aiming for is a really tense area of conjunctiva in the center there. You don't need to actually close across that area. Post-op management, we use lots and lots of steroids afterwards. I tend to use preservative-free steroids. So my regime is hourly for the first week while waking, every 2 hours for 3 weeks, and then 4 times a day for a further 2 months. So we have 3 months of steroid eye drops, antibiotics for 2 weeks only. And my general post-operative visits, if everything goes really well, they need to come at day 1, week 1, week 2, week 4, 8, and 12, and then you're through. If you need to remove any of the scleral flap sutures, if the eye pressure is good, the blood's not draining well, you should do that at week 3, which allows time for the anterior edge of the conjunctiva to heal. If you do it too early, you'll get a leak. So week 3 is usually optimal timing for that. So if they need to come back for week 2, you think, okay, I might need to bring them back. That's the time. So remember, mitomycin C-trabeculectomy can come with its own risks and benefits, but thankfully, what we need to remember is that the short-term complications that we see do not usually influence the long-term outcomes of trabeculectomy. And when you are carrying out your studies of trabeculectomy, this is a very nice paper, which was a redo of an older paper, but looking at the modern technique of trabeculectomy with the use of anti-metabolites. So it's a good one to compare when you're auditing your own data. I'm sorry about the videos. If anyone does want to see them, they're very welcome at the end to come and watch the actual videos. Thank you. Thank you, Dr. Verma, for reinforcing the steps of glaucoma surgery to TRAB, especially the gold standard. And I would open the house for any questions. Otherwise, we will move. Yes. Mike, did you let go? Otherwise, we have the last speaker here, and we can. Yes. Mike, did you go?
the front row.
बस इधर
Dr. Umar, thank you very much for nice presentation. I am really doing same placement that you are doing, but one maybe my suggestion, you are maintaining the anterior chamber with fluid during surgical procedure. Am I right?
Sorry.
You are maintaining the anterior chamber with fluid during surgical procedure?
Yes.
But my suggestion is what I am doing, that I make a side port from 150-degree light, complete the procedure, then at the end, and it will be shallow, you're right. Then we inject the regulate in the anterior chamber, so anterior chamber will be deep, and that fluid will come through this hole that you have made, and there will be valve formation. You can see on operation table a very nice valve, and there's no leakage from it. So what we do, that we at the end, we get the fluid and see the value of the blood that you get just now, because from side it is simple.
So you're absolutely right. So when the AC maintainer is removed at the end, the wound is hydrated, you will see the blood coming up. So we do that. But the beauty of the anterior chamber maintainer is that number one, you avoid the risk of suprachoroidal hemorrhage during the procedure, and secondly, it's to evaluate flow during. So your sclerostomy size, if it's too small, as soon as your flap is done, you will not get drainage. And whatever you need to do, you'll need to go back and enlarge your sclerostomy. So it's a good indication of whether your sclerostomy size is adequate. So
But
those are the reasons for
if you are saying there is suprachoroidal hemorrhage, then we are doing cataract surgery, we don't find suprachoroidal
No,
hemorrhage.
but
If you
intraveculectomy
give
is
us there, sometimes surgical procedures for 10, 20 minutes per general, we don't find.
You're absolutely right, but intraveculectomy, because you're going into the anterior chamber is going up and down. I've seen it on the table.
I think you practice my procedure, then you will be comfortable. You do one procedure and I switch.
I have used it without in the past. But this works.
actually it's your own choice. So either और क्लिनिकल स्टडीज की क्लिनिकल प्रैक्टिस की ड्यूटी ये है कि आप जो मर्जी प्रैक्टिस करें मतलब आपको अपना कंफर्ट जोन देखना होता है. It's about maintaining the AC. Okay, let's moving on to our last presenter, Dr. Khalid Hasni.
Madam, I have one question if you may allow.
Okay.
Thank you, madam. It was a
Dr. Huma, we have one question for you.
Thank you, madam. It was a beautiful presentation. My question is that you have pointed out that cataract formation is 25 to 40% in the intermediate or the late period. Is there any way to minimize the progression or the formation of cataract? And if there is a cataract formation in the early or the intermediate period, when do we exactly operate for cataract surgery? Because there is a chance of blood failure as well.
So I think if you look at there are some really nice papers in the literature looking at cataract development. So your risk of cataract is higher if you're a glaucoma patient that's treated. They're higher even more so with trabeculectomy, and then even more so again after tube surgery. So I don't think anyone's looked at how to prevent it, but I would say, be careful when you're performing your surgical iridectomy. When you're digging instruments into the eye and you're contacting the lens, potentially that's going to aggravate things. But I don't think we have any way of avoiding it. The second part of your question was about timing of cataract surgery. I would say not before a year. If you can avoid it. And again, if you want to reference, there are some really nice papers that Rahat Hussain has written from Singapore, looking at timing of cataract surgery after trabeculectomy and failure rate. The failure rate that I quote for cataract surgery, failure of trabeculectomy, is generally 20%. But the longer you leave it, the lower that will be. So at least a year.
Thank you, Dr. Umar. Now, let's hear.
My honor to be here today. Just by show of hands,
I'm just trying to get a sense of the crowd. How many people are glaucoma surgeons? Who's comprehensive? Who does like regular ophthalmology, like just comprehensive? And the rest are all glaucoma surgeons? Okay, all right. So this is, I think, should be a good talk for everybody. So we've heard quite a good few talks on trabeculectomy. And it's interesting because in Canada, there's a huge push towards MIGS procedures, angle-based procedures. And trabeculectomy is still the gold standard. Because, I train fellows and residents, and they're all excited about the MIGS and MIBS. I'm like, listen, you need to learn how to do a flap. You need to learn how to suture the conjunctiva. So you have to kind of, as a glaucoma surgery is coming to a new phase where it's quite exciting. There's so many different types of procedures out there, and trying to find the right fit where all the procedures fit in is the challenge nowadays. So it's a great time to be a glaucoma surgeon. So with that being said, the purpose of today's talk is to look at trabeculectomy versus tube. Which is better? And I'm just going to provide a practical algorithm for the comprehensive surgeon. Even if you don't do these procedures, just knowing how they fit in the paradigm of treatment just helps you guide your treatment. So we're all familiar with the glaucoma treatment landscape. We have a myriad of drops on the left, and then you have laser procedures, and you have MIGS procedures and MIBS procedures like xenopressor flow. And then you move towards the left, you have your trabeculectomy and tube shunts, and then your cyclodial procedures. So basically from mild, moderate to severe. We're going to focus on here, trabeculectomy versus tube. Keep it simple. Which is better? So why does this decision matter? Well, trab versus tube remains one of the most highest impact decisions a glaucoma surgeon has to make. The outcomes differ by patient, conjunctiva, disease stage. I would also add surgeon preference and surgeon experience. So we're trying to provide an evidence-based algorithm for comprehensive surgery, trying to figure out, okay, which is better? How are we going to make this decision? So the key questions that we have to ask is, has this patient had glaucoma filtration surgery before? Yes or no? And if they have had trabeculectomy filtration surgery, and you decide to do a trab versus a tube, and if you decide to do a tube, which is better? Ahmed valve or Behr valve? The reason why these two, basically Ahmed represents the valve shunts, and Behr valve represents the non-valve shunts. So we're going to look at 4 major studies. Keep it very simple. Take home points. The PT-VT study, the primary tube versus trab versus tube study. The trab versus tube study. The ABC, which is the Ahmed versus Behr valve comparison study, and the Ahmed versus Behr valve study, which is what I was involved with. I don't know if you know Dr. Ahmed in Canada. I was his first fellow. We were involved doing the Ahmed versus Behr valve study. So, primary trab versus tube study, the first study. These are patients who had no prior glaucoma surgery. Healthy eyes, healthy conjunctiva. Overall healthier population. So the question we're asking is, in first surgery glaucoma patients, should we start with a trab or a tube? So they compare trabeculectomy versus Behr valve. Patients had no prior glaucoma surgery, surgically naive eyes, healthy conjunctiva, lower scarring risk. So basically easier bleb surgeries. It's almost like if you're training your fellows or residents, these are the ones that you want to give them. So they're nice and easy conjunctivas to handle. What were the key findings? The take-home points. IOP reduction, trab was lower IOP at the beginning. But then over 3 to 5 years, IOP results were very similar between trab versus tube. Success rates. Trab had higher failure rates, mainly because of hypotony and wound leaks, wound issues. Tube had lower complications, but more long-term success. But in the end, 3 to 5 years out, they were very similar. Medication burden, because trabs had lower pressures, they required fewer drops in the first 2 years. Tubes needed more adjunct medications to keep it stable. And the complications, people who do perform these procedures know with trabs, you have hypotony, wound leaks, lab infections. Tubes are a little bit different. Diplopia issues, motility issues, corneal decompensation. So what is a practical surgical message? PT-VT, both trabs and tubes were both valid first-line options. Okay, trab offered best and lower target IOP at the beginning, but more complication risk. Tube, more reliable long-term, but needs more medications to help it out, and lower early complication risk. We always think of, even as a resident, I was like, tubes were the last end stage. But tubes can be considered a strong option, even as a primary surgery. They don't have to be considered last resort. So that was the take-home message from this first study. The second study, TRAB versus TUBE. These looked at patients who were more sicker prior glaucoma surgery. So in high risk, previously operated eyes, which works better, TRAB or TUBE? So they compared the outcomes of trabeculectomy versus Ahmed and Barabel tube shots in patients who had previous surgery, TRAB, extraction, cataraction, compromised conjunctival, high risk eyes, neovascular glaucoma, uveitic glaucoma, those sort of patients. What are the key findings? IOP reduction was effective in both. TRAB often achieves a lower early IOP, but less predictable long term. Tubes maintain more long term IOP stability, especially in high risk eyes or prior surgery. The success rate, TRAB had higher early failure risks, mainly due to body scarring and blood-related issues. And the tube had higher long-term success, requiring fewer reoperations and failure beyond year 3. The complications, similar to what the PTVT found, more high body and blood leaks and blood issues with TRAB, 2, more motility issues and renal decompensation issues. Medications, TRABs, fewer drops early on, tubes required more adjunct drops helped it out. What was the practical take-home message here? Tubes were better, dominant, more safer in the high-risk eyes. Prior surgery, uveitic patients gave field traps. It kind of makes sense. For those of us who do these surgeries, it kind of makes intuitive sense, but the study just kind of put it into numbers. Trabeculectomy is best when the conjunctiva is good, low scarring risk, you need low side. Overall, tube has better durability, TRABs lower IOP potential, but it requires more maintenance afterwards. Okay, so we talked about TRAB versus tube. Now we're going to say, okay, we're going to do a tube shunt. We'll proceed with tube shunt surgery, which is better? Ahmed valve versus the Bear valve. So Ahmed represents the valve type of implants. Bear valve represents the non-valve. So the ABC study and the ABB study. The ABC study was a comparison study between Ahmed versus Bear valve. This represented a more broader mixed population, and they had previously operated eyes, but the population was not as severe as the Ahmed versus Bear valve. And they were representative of a more general surgical glaucoma population. The Ahmed versus Bear valve study, similar comparison, but the patient was much more sicker. Prior glaucoma surgery, neovascular glaucoma, and traumatic glaucoma. They were representing a sicker population. So the IOP outcomes both showed that the Bear valve had lower IOP control, and Ahmed had higher IOPs, mainly because it's a valve versus non-valve. Medication burden, Bear valve had fewer drops compared to Ahmed. Okay. So success rate, both studies show that Bear valve consistently lowered the IOP long term. So when you're looking at these results, you're like, oh my God, Bear valve wins hands down, not so fast. It's double-edged sword because with the Bear valve being non-valve, pressure is a lot lower. Hypotony is the biggest enemy of glaucoma surgery. So this is where you have to take into consideration. So what was found at ABC, it was a more healthier population. The hypotony issues were more manageable. But with the ABB study, the same pattern was noted, but the hypotony issues were much more amplified because the patients were much more sick. So it was concluded that Ahmed valve would be more the safer shunt in these types of patients. So clinical interpretation. Ahmed, ABC, Bear valve wins for IOP success. Ahmed wins for safety. And finally, the ABB's, the Bear valve is better long term, which requires post-op manipulation, but Ahmed is much more safer in these patients. So you have to balance survival versus safety. So take home is PTVT. Tubes and TRABs are competitive in first-line surgery, with TRABs being better early and tubes more durable long term. TRAB versus tubes beat TRABs in previously operated eyes. And ABC and ABB, Bear valve, lower IOP, fewer meds, more post-op manipulation, better long-term success. Ahmed, safer early, but higher long-term tremors. So putting it all together, if you have a surgically naive patient, never had surgery before, really want those low IOPs, trabeculectomy gold standard, lower the IOP. Low side, Bear valve, lower durable long-term IOP with care for the body. Ahmed, if you don't keep the pressure that low, that probably has the safest profile. Previous surgery, putting all the studies together, Bear valve, best long-term success. Ahmed, safer, early in sick eyes. Trabeculectomy, just avoid it if you can because of heart failure rates. And if you have super high risk eyes, Ahmed is first line choice because of the safety profile. And if you need a second tube, one can consider doing parallel long term. So target IOP, if you want pressure really low, either trabeculectomy, naive eyes, bare belt, and scarred eyes, 12 to 15 pressures, bare belt probably the most balanced choice, Ahmed is fine. So take home summary, last best slide, I promise. Trabeculectomy, best for naive conjunctiva when you need ultra low IOP. Bare belt, best long-term tube for most eyes, especially previously operated, and Ahmed, safest for early, best for high-risk eyes. Then BG, BBS, and trauma. So these are just guidelines. Okay, so in reality, a lot of our decision is based on our experience, our resources of the hospital, what we have in our countries. So to say this way is the best, I always tell my fellows and residents, there's no one way is the best way. Get the pressure down and do it safely, right? So it all depends. Like some people just don't have access to it. So there's also newer devices like we have micropulse laser for cyclodiode. That's opening up a whole new avenue for some surgeons who aren't comfortable doing glaucoma procedures. I personally really don't care how you get the pressure down. Get it down in a safe manner. That's basically.
Thank you very much, Dr. And thank you very much, everyone, very guardians. I'm sure we must have picked up a few pearls to take home. And I'll give away for the next session. We'll invite